have a faculty. Yes, Dr. L. Ramakrishnan. So I'm taking this privilege to introduce Sir before starting the session. So he's a vice president of SATI. Dr. L. Ramakrishnan is a public health professional and vice president of SATI based in Chennai. He earned his doctorate in 2000 from the University of Texas at Austin, USA, and has worked in health and human rights non-profit settings in USA and India. As of 2018, his portfolio includes support to the MI3 Digital Health Initiative, to LGBTQIA plus inclusion programs, Empower, Access, and Vistara, Project Sampuya, and Project Svetana. He has previously led programs on mainstreaming and decentralization of HIV/AIDS services, legal and social protection for PL/HIV, use of ICT to bridge information gaps, program evaluation, and capacity building of implementers of health interventions. He's also involved in internal and external capacity building in areas of monitoring and evaluation, documentation, operations research, and gender and sexuality. So today we are going to have a really good session. And sir, we welcome you to the session, sir.
Yeah. Thank you so much. And once again, I apologize for the delay. I was on a flight from Kolkata to Aizawl, and the flight got delayed because of bad weather. So I'm right now in the airport at Aizawl, and I request someone to run the PowerPoints. I actually sent the PowerPoint by mail. Okay, great. Could you go into slide presentation mode? Yeah. Okay, great. So because of the limited time, I may skip. I would ideally like to see and have an introduction of all the participants. But since I'm running late, we might skip that. But I would still like to speak a little bit and get some input from the audience. So essentially, this presentation is about what people in the palliative care providers, what whether they are physicians or nurses or counselors or caregivers need to know, particularly regarding gender, sexuality, and mental health. And the focus here is, again, those of non-mainstream sexuality. So what we refer to, gay, lesbian, bisexual, in terms of sexual orientation, transgender and non-binary people in terms of gender identity, and also people with intersex variations. So can you just go to the next slide, please? Yeah. So I will do overview of the concepts around sexual orientation, gender identity, expression, and sex characteristics. But before I actually start, it would be great if we can have maybe 3 or 4 participants who are willing to raise their hand and share whether they have had, if they have had any exposure to the LGBTIQ community in therapeutic context, a clinical or a field context. Could we hear from folks? And I request the moderator to make this happen. Yeah.
Yes,
if you
sir,
can
sure.
see, since I'm logging in, you could see
Yes.
a show of hands and have people pick up, maybe 3 or 4 people. That would be great. Yeah.
Yes, so sir, would like to have few participants would like to have your hands raised, please.
So essentially, if you have worked with clients from the LGBTIQ community in your professional context and have some idea, please do raise your hand and share how that experience or what that experience was about. And if you have not had any clients in the LGBTIQA context, but you have some knowledge of the community through your either personal or professional networks, please feel free to share that as well. I'm just trying to get my finger on the pulse of where people are with regard to familiarity with the issue.
So we have a message from Narayanan. No, not much. So I think I'll read it out. Since I've been in HIV/AIDS sector, more on preventive campaigns and not much in care and support or clinical as such.
Okay.
So,
hi Ramki, this is Narayan from Accept.
Oh, hi, small world.
I know.
Yeah. Yes. Great. So, is there anyone else? in the participants, among the participants? Yeah.
We have Shivakumar sir has replied, sir, I have worked with transgenders.
Okay,
I
could
think we
he
have.
elaborate, please? Yeah. Could Mr. Shivakumar elaborate a little bit?
So it's texted, but that was about fractures and polytrauma.
Okay. Anyone?
Yes, sir. I have one experience because I used to engage in the Vandrewala group therapies for the LGBTQ. So as a
Okay.
psychology student, I was involving in that. So what I
Okay,
came
was it
to,
the queer affirmative counseling practice? Was it the course? Yeah.
as part of internship, I wanted to expose it to the community to understand
Okay.
it.
Okay.
So there was a situation, one of the community member was coming with that. So once he identified as a LGBTQ member, he was thinking that how can I go outside? So he has some inferiority complex and how the society will accept him and how can I mingle with the other people. And they were having a tendency to commit the suicide because he is unable to accept his own identity. So at that time, that was the scenario. And another scenarios related to means one LGBTQ person will not stay with the other LGBTQ person because of their intimacy requirements. So those are the two areas I could expose in those days, sir. Not much.
Okay. Thanks. No, fair enough. So let me actually ask a follow-up question that maybe there will be more volunteers for. Even if you have not had prior experience interacting with the community, except for the couple of you who have had some exposure, maybe 2 or 3 folks who would like to share based on the limited background. Why do you think palliative care as a session or as a course requires to be cognizant of members of the LGBTQIA community? I mean, do you expect prima facie any difference between how a palliative care provider will deal with members of the LGBTQIA community? Or do you expect that LGBTQIA members will have any different or additional set of challenges in seeking and receiving palliative care than people who are not from the LGBTIQA community? So maybe a couple of people can share that based on what you might. Please go ahead.
Yeah, for LGBTQ, yes, sir. Please go ahead.
No, you can answer, and then we can ask a couple more people. Please go ahead.
Yes. The thing is, sir, why we need palliative care for the LGBTQ means number one thing, they are less treated, less aware of the people, and there is some stigma about the people. So if we become more aware of the LGBTQ community, so they can be better served by the palliative care, and they will be accepted by the society. Number one, and the number two is so some people. LGBTQ persons, they will want the same kind of community people to be with them so that they will be more comfortable when they are getting the treatment. These are the two things I think.
Okay, can you hear me? Yeah.
Yeah.
Okay, so the first point you said was that the care providers need to know more in order to be able to provide informed care. And the second thing was you speculated that community folks would like their care providers possibly to be also from the community. Fair enough, very good points. I see Neha has raised their hand. Neha, could you go ahead?
Yes, sir. So honestly, to start off with, that was my first question that I had when I saw the session scheduled. That how would that be different? Wouldn't it be almost the same for everybody? But post that, when I thought about it, I did feel that it can be a lot around the stigma that is already posed. That a lot of factors around with it, and also the healthcare provider, the palliative healthcare provider, to be aware of what are their beliefs, or what are their, what all have they been, what is their thinking like, things like that would definitely help them in terms of taking care of that person. Is something it's as small as just addressing them, how to address them, what are their pronouns. Things as small as that can also make a difference. That's what I think.
Okay, yeah, no, those are great points. So on the face of it, they should not receive any different care. But yeah, I think sometimes there may be ignorance or lack of familiarity on the part of the provider, and that can reflect in what may appear to be insensitive, but is actually coming from a place of ignorance regarding pronouns in the case of transgender people. Or to add about that, very questions that are otherwise treated as normal questions, like do you have a husband, do you have a wife, where we make assumptions of heterosexuality. So things like that. Jayanto Ghosh, please go ahead.
Yes, sir. As I got into in depth of this course, I felt that palliative care is an area which should be inclusive to make its true impact in the society. And in order to become this inclusive, it must include all the sections of the society and leave no one behind. Then only palliative care or care scenario can be a very friendly and inclusive aspect in the society, and we can give comfort to all those who are ailing. So LGBTQ obviously needs to be a part of this course. This is the way I think so.
Okay, that's great. So if I understood you correctly, what you're saying is, in order for palliative care as a science or as a field to be more inclusive, you need to know about people who are in the margins of society, and who may or may not have the same concerns as everybody, or they may have additional concerns. Okay, fantastic. So we've heard from Neha, from Joyanta. Anybody else?
So we have few chats from Kavita.
Could you read out? Yeah.
Yeah, so mostly they will not accepted, they're not accepted by the family, so they need palliative care than anybody else. So that's one answer.
Okay.
And then we have a
Okay.
message from Narayanan. Acceptance of LGBTQ in general settings itself is quite challenging. Also, palliative care is more about holistic approach to care. The social aspects of LGBTQ are quite unique. Then we have from Shiva Kumar. While I was working as a hospital administrator, a member of the LGBTQ community, a patient refused to be treated by a female nurse and posed a serious problem in providing treatment. The patient had severe trauma issues. So these are the messages that we've received.
Okay, okay. Yeah, I think people are generally getting the idea, or already have the idea. So to approach these in a little bit of a structured aspect, and also accounting for the fact that possibly some people have not had exposure, I will talk a little bit about the basic concept of what we call SOGIESC. SOGIESC is SOGIESC, which stands for sexual orientation, gender identity and expression, and sex characteristics. So these are the different axes along which we think of the LGBTIQA community. For example, a trans person is not the same as a gay person, though there may be some similarities, there are also striking differences. So once we have that conceptual framework down, we'll go specifically to the mental health impact of the stressors faced by society. Some of you have already said that whether it is in healthcare settings or in society at large, there is less understanding / acceptance of the community, and all of these can be seen psychologically as stressors that have impact on mental health and physical health of the community members. So we look a little bit at that mental health impact, and we look at stressors from family, society, and health, and then specifically go into barriers accessing palliative care and some best practices, which are unfortunately right now restricted to literature in the global north, that is North America and Europe. We don't have a whole lot of literature in the Indian context. There is one exception of Dr. Samira, who is critical care physician. She used to be in Pondicherry at Mahatma Gandhi Medical College and Research Institute, a critical care physician and a transgender woman herself. So she was just beginning some research on palliative care needs of the transgender community. But then she moved abroad. So she's right now with the NHS in the UK and continuing the work. But hopefully we'll get some research that is done in the Indian context out of her work soon. In fact, Dr. Samira is the person who first did the sessions for Pallium India, and then I took over after we were doing some joint sessions and after she moved. So could we have the next slide, please? Yeah. Okay. So as I said, the LGBTQIA spectrum can be viewed along the axis of sexual orientation, gender identity and expression, and sex characteristics. So if I look at sexual orientation itself, it's part of a broader notion of sexuality, which people break into sexual behavior, sexual identity, and sexual orientation. So in very simple, non-technical terms, sexual orientation is whom you're attracted to, sexual behavior is who you have sex with, and sexual identity is how you identify with respect to your sexual orientation. So let's say a person who is a man, not a trans man, but a cis man, and who is assigned male based on the body parts he was born with as a child and identified as a boy and then a man, is attracted only to other men. His sexual orientation is what we would refer to as homosexual. His behavior may or may not be homosexual, depending on the society he grows up with, the restrictions he faces. There could be a situation where he is forced to get married and have sex with a woman, so his sexual behavior may not be homosexual. And depending on how accepting his social environment is, he may or may not identify himself as homosexual, or the more commonly used term as gay. So in this particular case, the orientation is towards men, towards the same gender. The behavior may or may not be towards the same gender, and the identity may or may not be gay or homosexual, depending on how restrictive or permissive the society is. Now, this is important in a couple of contexts. One is, if you are a palliative care provider and the individual that you're providing care to has been raised in a very restrictive setting where it was not at all permissible for the individual to be out as gay or homosexual. Maybe the person has not even disclosed his sexual orientation and identity within the family. So you can't go in there with a checklist and saying, what is your sexual orientation? You might not get a truthful response if family members are around. So this calls for some amount of discretion, and if you sense that the individual is a bit uncomfortable talking about their partner or about their relationship or status or whatever, you may actually need to create a situation of some amount of privacy, even from immediate family members if they happen to be around. The other aspect, of course, is that if the person were actually open, or people had discovered this person's sexuality and were not accepting, as is the case with a lot of folks, they may not actually have any natal family or biological family, because many individuals from the community are actually abandoned by their family, or they run away from home, especially folks from the trans community, to avoid further violence and harassment or forced marriage. Okay, so this is sexual orientation. Can you go to the next slide? Yeah. So there are a lot of terms which I'll quickly go over, and you will have access to the PowerPoint. I've shared it with the organizers, so you can read these at leisure. But broadly, terms like gay are the identity corresponding to primary attraction to other primary or exclusive attraction to the same gender, coupled with lack of attraction to another gender. So just because a man is attracted to another man does not necessarily make him gay. He could actually be bisexual, in which case he would be attracted to more than one gender. And even here, there's a misconception that a bisexual person has equal attraction to multiple genders. That's not the case. Okay. Yeah, so that's bisexual. Heterosexual is the probably the majority of people who are primarily attracted to the other gender and who are not attracted to the same gender. Lesbian is an identity term referring to a female homosexual person, a woman who's attracted to other women and not attracted to men. Pansexual is similar to bisexual. When we talk about bisexual, we talk about attraction to more than one gender. In pansexual, we talk about attraction which is independent of gender. So there are people who will say, I'm attracted to people for other qualities. What is their gender or what's between their legs is not a critical factor in my attraction to them. Asexual is a person who is not interested sexually in other people. And then there is also an umbrella term queer, which was originally a pejorative term, but now it's a term of that's been embraced by the community. And the term queer can be used in a couple of contexts. Sometimes queer is used as an umbrella term to refer to anyone who is L or G or B or T or I. And sometimes people who don't feel that they necessarily fit in one of these boxes, but are still different from the mainstream, may use the word queer to identify themselves. Yeah. If we have questions in this, we can address them in the Q&A. Can you go to the next slide, please? Okay. So I talked about sexual orientation. Now I'm talking about gender and gender identity. Most of you who've had some amount of social science as well as life science in college would have probably learned that, sex is biological and gender is social. This is partly true, but not fully true. So it is true, and if we go by the World Health Organization definition, that gender is socially constructed and refers to roles, behaviors, and and attributes that are considered appropriate for men and women. So notions that a man is aggressive, assertive, physically active, interested in outdoor sports, and a woman tends to be more domestic, more interested in playing with dolls, etc., etc. These are obviously stereotypes, but if the point is that if somebody who is a male assigned child who is born with male genitalia and raised as a boy and expected to grow up into a man does not exhibit some of these stereotypically male typical or masculine traits, such a child or such an individual will face everything from bullying to harassment to violence. So it may start off as just harmless teasing in school, but it can escalate. So gender is what really society expects as normative or appropriate behavior for people who are male and for people who are female. But in addition to the social aspect of gender, there's actually an intrinsic aspect, which in the psychiatric and psychological literature is called gender identity. Here we have the definition of the American Psychiatric Association, which is basically saying that apart from what society says, how a boy should be and how a girl should be, an individual growing up, even pre-puberty, has a very strong sense that, I'm a boy, I'm a girl, or I'm both, or I'm neither. And this is what we refer to as gender identity. So if let's say we have a person who is biologically male, and we use the term assigned male at birth, and the person is brought up as a boy, and the person also self-identifies as a boy, then the sex, the gender, and the gender identity are all aligned with each other. And such a person is referred to as cisgender, CIS gender. On the other hand, if the individual grows up with a gender identity which is different, so the child is male assigned, raised as a boy, but has a very strong inner sense that I'm a girl. So the gender identity is at variance with the gender and the biological sex. Such an individual is called transgender. And a transgender person could be biologically assigned male at birth and identify as a woman, or could be assigned female at birth but identify as a man. And there are also people who identify as neither or as third gender. So anyone who does not identify their gender identity in concordance with the social gender and the biological sex is called transgender, and everyone who does identify concordantly is called cisgender. And cis and trans are terms borrowed from organic chemistry for those who might be familiar. So just go to the next slide, please. Okay, so we have some more terms here. So transgender is a gender identity which is contrary to the gender assigned at birth. And the gender assigned at birth by society is typically based on biological sex, basically what body parts the individual is born with. And sometimes it can be based on internal features like chromosomes, tissues, etc. So there are children, for example, who are born with perfectly female looking body parts and who are raised as girls. But when it comes to puberty, they do not develop the secondary sex characteristics. They don't develop breasts. They don't menstruate. At that point of time, the concerned parents may take what the person they think is their daughter to a doctor who may do a karyotype, look at the chromosomes and find that actually the individual has XY chromosomes, but has physical external body parts that look female because of something we call an intersex variation. I'll come to that later. But essentially, a transgender person has a gender identity different from the social gender, which in turn is assigned at birth based on the external evidence of body parts. So someone who is not transgender is cisgender. And within transgender people, there are binary transgender person, a person who identifies as a trans woman who is assigned male at birth, a person who identifies as a trans man who is assigned female at birth, and people who identify themselves as non-binary, who often go by the pronouns they and them, who don't consider themselves fitting in either box. Now, one important part to note here is that gender identity is independent of sexual orientation. So just because someone is a trans woman, you can't assume that the person is attracted to men or of a particular gender. Trans woman may herself be lesbian, she may be heterosexual, she may be bisexual, she may be pansexual, asexual, etc. And in India, the trans feminine identities, that is, people who are assigned male at birth, but who identify as women or as third gender, are a lot more visible in the society, and there are sociological reasons for that. But terms like Nupi Manbi in Manipuri, Hijra and Kinnar in Hindi-speaking areas, the term Tirunangai in Tamil Nadu, the term Aravani in Tamil Nadu, are all terms in local languages for transgender women, or what we refer to as trans feminine people. There are relatively fewer terms for trans men. The term Tirunambi in Tamil and Nupa Manba in Manipuri are the two exceptions. I think there is also a term Babu Bhai from Gujarati, which refers to trans men. But in general, there are a lot of Indian words for trans women, and which also suggests that there is much greater visibility of trans women compared to trans men in our society. And again, people who are gay, lesbian, bisexual, who are not transgender, are relatively invisible unless they actually come out and say that this is their orientation and identity. Any questions right now before we proceed? You can raise your hand or you can type in the chat.
Any questions? You can also use the chat box.
None? Can we move?
I think, yes, sir. I think we can move. We don't have any.
Okay. Could you go to the next slide, please? Yeah. Okay. So apart from an individual identifying their gender as, I'm a boy or I'm not a boy, or I'm both or I'm neither, there is just the behavioral aspect which we call gender expression. So some of you may have seen growing up that there was a male child who behaved in a very feminine manner and who probably liked to play with dolls, didn't like playing cricket, preferred to hang out with other girls of his age rather than boys of his age. And such a child is typically, bullied and teased in school and among peers. So this is a child having what is called gender non-conforming expression or gender non-conformity. Now, when that child grows up, we don't necessarily know that the child's gender identity will be trans or something else. It could be, it may not be. But the fact is that regardless of that child's gender identity, the expression itself is sufficient to warrant bullying and harassment from peers, right? So gender expression is a term that describes the ways in which a person manifests masculinity, femininity, both or neither. It could be some combination of speech pattern, how the child or the young individual talks, walks, chooses to dress, etc., etc. And if the gender expression is non-conforming, as we saw, is the child may face bullying and violence. One data set that we have from the organization Sati, which I work with, we had done a survey in West Bengal, Jharkhand, Manipur, and Odisha of nearly 13,000 trans adults. And nearly 30% of them had dropped out by 5th standard because they could not stand the bullying that they faced because of their gender expression. Before 5th standard, most of them probably didn't even know what the term transgender was, but their gender expression was what elicited a lot of teasing, causing them to drop out. So in general, the dropout rates in the country are much higher for children with non-conforming gender expression, regardless of what their orientation as adults or their identity as adults may be. Okay, could we go to the next slide, please? Yeah. So, so this point here, it's just a continuation of talking about gender expression. So a child with gender expression that does not conform to what is expected of that child in terms of maleness or femaleness is what we refer to as non-conforming gender expression or gender non-conformity. And as I mentioned earlier, a gender non-conforming child may, as an adult, identify as anything, may identify as heterosexual, gay, lesbian, or bisexual, or transgender. One cannot necessarily predict gender identity or sexual orientation from childhood gender non-conformity. However, if you ask adults who are LGBT, many of them report being gender non-conforming as children. And again, gender non-conformity or equivalently non-conforming gender expression is not an identity. It's what people feel looking at the child, that the child is not behaving the way a boy child should behave or a girl child should behave. But so it's what other people think of that child based on how the child expresses their gender. And this itself, as I said, can result in a lot of teasing and violence and bullying, including sexual violence from peers and from teachers and from staff. Okay, can we go to the next slide? Okay. Apart from all of these, okay, just give me 1 second, please.
Yes, sir, yes.
From these terms of, we talked about gender identity and gender expression, there is a term called gender dysphoria, which is again a term coming from the psychiatric literature, where a child is extremely uncomfortable with the gender assigned to the child. So you may have a child violently exclaiming that I'm not a boy, and the child may refuse to stand up and urinate. The child may be a female assigned child who just hates having long hair and wants to cut off the hair, etc. So there is a psychiatric quote unquote diagnosis called gender dysphoria, which is acute discomfort with assigned gender. And many of these children, though not all, may also have a desire to modify their body. So when you hear of transgender individuals having a surgery, which is called now a gender affirming surgery, it used to be called wrongly sex reassignment surgery. It's because of the distress that we refer to in psychiatry as gender dysphoria. Now, the term gender dysphoria itself is a term from the American Psychiatric Association. As per the World Health Organization, the term now is gender incongruence. But one important thing to remember is until very recently, until 2018, the World Health Organization used to refer to this as gender identity disorder, saying that it is a disorder if the child has an identity, a gender identity different from the assigned gender. But with more and more evidence coming out, and they've looked also at the commonness, how common being not aligned with the assigned gender is. So the term gender identity disorder was removed from the ICD, International Classification of Diseases, Volume 11 of WHO, and it has been replaced by gender incongruence and removed from a pathology section. So right now, what we understand is, just like we talk about variation, the people who have variation in right-handedness, left-handedness, there's variation in sexual orientation, there's also variation in gender identity, where a certain subset of every population, maybe 5 to 8%, has a gender identity which is different, which is incongruent from what was assigned at birth. Okay, could we go to the next slide? Okay, so I talked about sexual orientation, I talked about gender identity, I talked about gender expression, and about gender dysphoria. Now I'm going to a very, very basic concept that we think we all understand, which is that of sex. Okay, so biological sex, which we all think we understand, and if asked to explain what sex is, we may explain it using references to external or internal body parts. So you have a penis and you have a scrotum, or you have a uterus, you have ovaries, etc., etc. That's what makes you a man or a woman. A person who knows some genetics will tell you that male has, apart from the autosomes, will have an X chromosome and a Y chromosome, one inherited from each parent. So the female will have XX chromosomes. A person who is well versed in endocrinology will probably tell you that males have a preponderance of androgens like testosterone compared to estrogens, and females will have more estrogens than androgens. So these are all different ways of conceptualizing maleness and femaleness biologically, in terms of external or internal body parts, in terms of chromosomes, in terms of relative proportions of hormones, etc. However, this, again, we have an assumption. Just like we assume that the biological sex will align with gender, which will align with gender identity to give you a cisgender individual, here also we have an assumption that the external body parts and the internal body parts and the X and Y chromosome and the relative proportion of the hormones will all align with each other. For example, a male child will have, or a male individual will have XY chromosomes, will have more androgens, will have a penis, scrotum, etc. A female will have XX, will have more estrogens, will have the corresponding, vulva, uterus, ovaries, etc. But this concordance is not always the case. You actually, as I gave the example earlier, there are children who are born with an external female phenotype, but actually have XY chromosomes. If you go to the next slide, maybe there's a picture of that. Can you go to the next slide? Next slide. Here. Okay. So here the picture on the top right shows a range of what we call atypical genitalia or ambiguous genitalia that change, that vary from looking perfectly female to looking perfectly male, and a lot of intermediate categories. Now, all these variations are examples of what we call intersex variations. The term for it in developmental biology and in pediatrics is DSD, which is differences in sexual development. And that particular example we see of a variation in how the external genitalia look is one of nearly 40 intersex variations. And this is something called androgen insensitivity syndrome. So in this particular case, the child is born with XY chromosomes, but during development, the fetus, while undergoing development, does not respond to androgens. And as a result, the external body parts look female, which is kind of the default body parts, the default anatomy. And this, how much the body responds to androgens or is not responding to androgens, is variable. So if the individual has complete androgen insensitivity, the XY fetus grows to be, is born as a fetus, as born as an infant looking female in terms of the genitalia. If the androgen insensitivity is not complete but partial, you'll have these various types of atypical genitalia. Okay, and so these are all not to be confused with transgender individuals. These are all intersex variations, and some intersex individuals may have a gender identity which is different, and they may be transgender, but a lot of intersex individuals may not have a different gender identity, they may be cisgender. So don't get confused between transgender, gender identity, and intersex variations. And apart from this androgen insensitivity syndrome, there are situations that you may have studied in biology, like Klinefelters and Turners, where the number of sex chromosomes, instead of XY, you have XXY, or you just have an X, etc. These are also examples of intersex variations. Okay, so these are individuals with atypical genitalia. Sometimes the genitalia may look like, in the case of the previous slide, sorry, the same slide, the top left, the genitalia do not look ambiguous in the image on the extreme left, it looks female. So such an individual would not be detected to be intersex until adolescence, when the child does not develop breasts or does not undergo menstruation. So it's not always that an intersex individual is identifiable at birth, may be identified only later. And there are probably some individuals who are intersex who don't know it at all, because not all intersex conditions have a bearing on fertility and things like that. So you may have individuals who look gender non-conforming, sorry, you may have individuals who look sex typical and who do not have a visible or a noticeable intersex variation. Okay, could you go to the next slide? Yeah, just okay. Now, when you look at the LGBTIQ community as a whole, if you can show the text on the slide, yeah. Very often you have arguments that this is not found in our culture, and that is often used as a basis for objection, or saying that you can't be gay, you can't be trans, is all not part of our culture. But there are plenty of examples. If you look at indigenous communities, like the photograph on the left is a community in Manipur where trans children are treated as having divine powers and are really respected. We have evidence from sculptures from everything from Konark to Khajuraho to Mahabalipuram and other places, where you have depictions of same-sex behavior. You have the figure of Ardhanarishwara, who's a sort of bilateral androgyne, one half looking male, one half looking female. Now, we cannot make a one-to-one correspondence between how people were depicted then and what the identity is. But just to say that non-normative sexual behaviors and bodies were known in our culture, and the argument that they are not part of our culture is wrong. Yeah. Can you go to the next slide? Yeah. There are also arguments that this is not part of nature, that being LGBTIQ is unnatural. But there are examples from nearly 450 species of vertebrates and invertebrates showing that it's actually very much found in nature. Okay, just one second. Excuse me, mera nahi aaya. Baggage hasn't come. Yeah.
No problem,
So,
sir. No problem. Yes.
yeah. So I'm trying to find my baggage at the same time. If you can go to the next slide. Yeah. So there are examples from primates, from other mammals, from birds, etc., showing that you have actually evidence of individuals with same-sex behavior forming pair bonds, and those pair bonds last for a long time, showing that this is very much part of nature as well.
Sir, I think you're on mute. Dr. Ramakrishnan.
Some drama that
Okay, no
the
problem,
flight,
sir.
because of bad weather, the flight was diverted from Aizawl back to Kolkata, and I'm finding myself in Kolkata right now.
Understood, no
Because while my
problem.
back did not arrive.
Yeah.
Yeah, so I was making the point that this is all, there's enough example that this is part of Indian culture. Yeah, the previous slide, and this one is that it's a part of nature as well. So these two slides illustrated variation in among different species. Could we go to the next slide? Yeah. Okay, so what are the problems faced by the community? So society as a whole emphasizes male-female relationships, emphasizes getting married, emphasizes having children. So anyone who deviates from this is considered to be quote unquote abnormal or perverse, etc. This has a lot of mental health impact on the community, and this can result in suicidality. And there are also unethical and unscientific attempts by doctors who promise that they will change the sexuality of a gay man to straight, or the gender identity of a transgender person to cisgender. So this practice was officially banned by Kerala High Court and Madras High Court. And now there's a circular from the National Medical Commission saying that if a doctor practices this conversion therapy, their license will be revoked. Yeah, so, but these are all some of the stressors faced by the community. Can you go to the next slide? Okay, so now if we look at mental health, there are issues like the stigma against LGBT people translates into low self-esteem, depression, anxiety, eating disorders, substance use, self-harm, suicidality, and other mental health problems. Okay, so these are all the very different impacts of having a non-normative gender or sexuality. Next slide, please. Yeah. So here is data from North America. The upper right image is of sexual orientation. So the summary here, who are being bisexual have had more thoughts of suicide and more attempts of suicide. If you look at the graph, the figure on the bottom is basically saying that transgender people have higher rates of suicide and also experience a lot of other problems like lack of family acceptance, inability to find mental health care, homelessness, mental and physical health care, homelessness, inability to change their name and gender on their official gender IDs, etc. So these are some examples of the mental health consequences of being LGBTIQ. Next slide. Yeah. Okay. If you look specifically as how these stressors impact children, the teasing faced by gender non-conforming children, it could be verbal, physical, emotional, sexual, leads to psychosocial outcomes like isolation, not feeling like they belong, anxiety and depression, and suicidal ideation, all of which has a grave impact on educational outcomes. Fall in grades, loss of educational aspiration, increased absenteeism, dropouts, etc. Yeah, okay. Next slide, please. Yeah. Okay, so what does the law say? No discussion on this is complete without discussing the law. In the mid 1800s, we had the colonial, what was called the sodomy law that we inherited from the British, which said that any relationship that does not involve a penis and a vagina is criminal, regardless of whether the individuals involved are consenting or non-consenting. As of 2018, this has changed through a Supreme Court verdict called Navte Johar. So it is no longer a crime to be in a physical or otherwise relationship with somebody of any gender, as long as both individuals are adults and it's consenting. And also since 2014, transgender people have protection under the law through another Supreme Court verdict. So a trans person can legally change their name, change their gender through a certificate. Maybe you need a letter of endorsement from a clinical psychologist or a psychiatrist, but that is enough. Even surgery is not a prerequisite. Yeah, go to the next slide, please. Okay, we can skip this. This is basically some early evidence that was given by Dr. K.S. Jacob, who was the head of Department of Psychiatry at CMC Vellore, Christian Medical College Vellore, who was one of the earliest psychiatrists in India to actually speak out against the practice of conversion therapy. And nearly 15 years after he spoke out, the actual change came, where conversion therapy is now outlawed, at least in 2 states, and by a directive from the National Medical Commission. Next slide, please. Okay, so here we get to the core of the reference to palliative care. So some of the factors we need to keep in mind are the fact that individuals from the LGBTIQ community may be estranged from their natal families. Their relationships may not be recognized. They may have experienced everything from hostility to indifference in healthcare settings. Very often, it may not even be the doctors, the ward boys and nurses. How they treat a transgender person varies and can be quite hostile. And also, the healthcare provider, the palliative care provider, will just assume that people they see are heterosexual. They must have been married, or they must have been married in the past, or they're currently married. And they may not even, unless the person is visibly different, it may not even occur to them to think that the person may actually be from the LGBTIQ community. And I said not everybody from the LGBTIQ community looks different, right? Trans people may look different. Gay, lesbian, bisexual people who are not trans may not look different. So these are all among the barriers. Please go on. Yeah. Next slide, please. Okay. So here's a paper that came out in Oncological Nursing in 2018. And some of the conclusions and recommendations from the study were that you may not know the sexual orientation or gender identity of the person, but you have to create an environment where it is safe for the person to come out and tell if they have a different gender identity or sexual orientation. And if you create, so don't jump to conclusions based on their appearance and behavior. If necessary, give them the privacy away from even immediate natal family members to be able to disclose. So if you do this, you can contribute to greater comfort levels, higher overall healthcare satisfaction rates, improved relationship between the provider and the client, better sense of well-being, and enhanced quality of life for LGBTQ patients. Now, the term I intersex is typically not there in many of the studies. In fact, there's very little data on intersex patients and their experiences in palliative care. Can you go to the next slide? Yeah. Okay. This is from the same paper. Okay. So the recommendation is understand the lived experiences of LGBTQ patients through their experiences of multiple external and internal stressors, which may have started off at home, it may have started off at school, it may have continued into workplace, it may have continued into healthcare settings, etc. Be aware of your own biases, and they may have had bad experiences. Many trans people in particular have very poor healthcare seeking behavior. They dread going to a healthcare provider because of past experiences of discrimination. So when you make inquiries about their families, you ask, is there anybody other than your biological family that you're close to? Do you have any partner that you want us to inform? Because these may not be recognized by law. We've seen in India that as of last week, there was a Supreme Court verdict that did not recognize a marriage, and that's a struggle will probably take a couple more decades. But yeah, so there are ways in which you can elicit this information from the client by creating an environment that is open-minded and thoughtful and gives the individual some privacy also to answer. Next slide, please. Okay, this is Javier. This is another article about palliative care and social practice journal from January 2021. So when you're doing physical examinations of people, you should also understand that if you find a body part that's unexpected, for example, a person who is a trans woman but has not had the financial need the financial ability to undergo surgery. You might be surprised if you do a physical examination. So the important point here is you do the physical examination with a lot of respect, asking for permission, asking for consent, and sometimes also asking people, what would you like me to refer to this body part as? And a specific example here, there are transgender men who have not had the ability to do a phalloplasty, which is a penis reconstruction. At the same time, they have a lot of gender dysphoria about their body part, and they may not refer to their vagina as a vagina. They may just refer to it as a pee hole. So best thing to do is to ask them how you refer to the body part in a situation where you need to do a physical examination, and openly discuss the purpose of doing the examination. Allow patients to teach providers about naming body parts and the significance of respectful touch in order to create support, to build support between the provider and the client. Yeah. Next slide. Yeah. Okay. So I think we're stopping here. There's a few more readings that you can do if you're interested in knowing more about this. Now it's 4:30. I think I have to run and figure out my next flight. So I'm just wanted to ask the moderators if it's possible that if people have questions, could they mail it across and I'll be sure to answer them.
Yes, sir. Yes, sir. We understand that you need to go. Yes, we can. Sure,
Yeah.
we can. Yeah, so I
Okay.
hope everyone can see the mail ID. It's L Ramakrishnan, RAMAKRISHNAN at Sati, SAATHII.org. So you can note down, and surely feel free to mail sir about your queries and any clarifications or doubts. Sir will be answering.
Thank you very much, and my sincere apologies for the nature of the session. It's a
No
little
problem.
bit uncertain. Yeah, thanks. Yeah.
Yes, sir. Thank you so much for your valuable time in the midst of this busy schedule. Yes, sir.
Thank you. Thank you so much.
Yes,
Bye.
sir. Thank you. Sure. All right. So I hope everyone can note down the mail ID which sir has provided, and you can all can surely. I'm sure that you will be having a lot of questions in this session, lot of queries and clarifications on this topic. So surely you can mail, and also you can reach out to us as well. Right. So thank you so much, everyone. Over to you, Sri Priya.
Thank you. Sangeet, maybe we can come out of the slides. Yes, we do understand that we are not capable of answering maybe your queries on such a delicate and very less discussed topic. And Dr. Ramakrishnan was very, very supportive, and you have seen him, like he's in midst of traveling. There were a lot of commotions going on, and still he managed to enlighten us on this particular topic. So as he and Devika already said, you may please mail to him regarding your queries. Anything else we could take up before we wind up for the final time?
Yes.
Any pressing queries, comments? So that brings us to the end of our journey of 16 sessions of foundation course in palliative care. We do believe that these sessions, the knowledge received from these sessions will definitely will equip you better in handling palliative care. And we do look forward to hearing more and more experiences from your field of work in coming days. So Devika, would you like to share any final words so that I can?
Well, I think, yeah, it's quite hard that this is going to be the last session with all the participants. Well, I think we had very few sessions with me as well, facilitating this. But I'm so happy that, I'm so happy to get a lot of positive feedbacks from people that it actually these sessions help them. And I'm sure that this is going to grow, and we are going to have more sessions. And yes, we are also on the way to prepare more advanced sessions on palliative care. And hopefully we are going to see the same faces again for that advanced sessions, right? And we'll be keeping in touch. As Sri Priya said, we'll be having the WhatsApp group where we'll share. and you can always keep in touch. And we have received few messages from few of our participants regarding the observationship. Surely we would like to have you here at Pallium India for more exposure, hands-on experiences, to see palliative care, home cares, and our activities. So you can surely contact with HR. Yes, so I think I'm happy to be here, but at the same time, a little sad that this is going to be the last session. But yes, we're going to see the similar faces again. Thank you, Sri Priya. Thank you for
Thank you
giving me the
everyone
opportunity also to facilitate. Yes, yes.
Thank you everyone for joining us, and with a note that we will be keeping in touch. This is Sri Priya along with Mr. Sangeet Krishna and Ms. Devika Rajendran signing off from the Tips Echo Hub for the last time. Stay connected everyone, keep spreading happiness. Bye-bye.